Falls, a geriatric syndrome. I also read a quote that I felt very suitable to put in this presentation, and it states, "It takes a child 1 year to acquire independent movement and 10 years to acquire independent mobility. An old person can lose both in a day." Geriatric syndromes are a clinical condition seen by the elderly that do not fit into discrete disease categories, such as falls, urinary incontinence, sleep disturbances, dizziness, and syncope. Falls have been defined as unpredicted and natural accidents that occur within the elderly. Of community-dwelling adults older than the age 65, 30% are estimated to fall, and those older than 80, 40% are estimated to fall. 50% of patients in a long-term care facility fall. 5% of people who fall require hospitalization, and 75% of falls in adults older than the age of 65 result in death. It's common in elderly patients to not report falls as they feel like they are normal occurrences with aging, or that they could be placed in a nursing home. Falls commonly are reoccurring, which lead to functional limitations. The falls could be the result of an underlying condition or medication adverse effect. Therefore, to nursing, it is very important to have thorough assessment and interview skills with these patients. The patient in this case study had no known drug allergies. She was on several medications, including hydrochlorothiazide and lisinopril daily for hypertension, Protonix daily for GERD, simvastatin daily for hyperlipidemia, vitamin B12 daily for vitamin B12 deficiency, Synthroid for hypothyroidism, and meloxicam for osteoarthritis. She was up to date on all of her childhood immunizations. She took her yearly flu vaccine. She was up to date on her pneumococcal vaccine and all of her boosters. Her screenings included mammogram, colonoscopy, DEXA scan, pelvic exam, vision exam, and dental exam. These were all with no abnormal findings, and we also performed a depression screening in the office. The patient's past medical history is hypertension, hyperlipidemia, vitamin B12 deficiency, hypothyroidism, osteoarthritis, and GERD. She was hospitalized 5 times. The first one was as a child. She was unsure of the age, and this was for an appendectomy. She was hospitalized in 1974 for a vaginal birth, again in 1977 and 1981. In 2016, she was hospitalized for influenza, pneumonia, and dehydration. She lives at home with her husband, and her daughter lives next door. Typical presentation and common complaints of patients with falls could be pain, bruises, dizziness, head injuries, brain hematomas, or even fractures. A review of systems that you can explore would be neurological, musculoskeletal, cardiovascular, or even respiratory. The patient in this case study, her blood pressure was 138/72. Her heart rate was 83, and it was regular. Her respirations were 16. Her temperature was 97.9 oral. Her O2 saturation was 97% on room air. Her height is 5'6". Her weight is 146.2 pounds, which gave her a BMI of 23.6, which is a normal weight for her. During this visit, we performed 4 screening tools. The first one was the Tinetti Gait and Balance Assessment Tool, and the patient scored a 25. This put her at a low risk for falls. However, we were then triggered to perform the Home Safety Assessment Checklist. This was performed by interviewing the patient. However, we did determine that the patient had multiple scatter rugs that were not secured. She also had hardwood floors and did not wear non-skid socks. She had a stairwell with no handrails. She also has areas of her yard that are not well lit and the home that are not well lit. We then performed the mini mental state examination, and the patient scored 28, which does not indicate cognitive impairment. The geriatric depression scale was also non-suggestive of depression due to the patient scoring 3. Although there is no definitive way to determine if a patient is going to fall, there are several diagnostic and labs that you can order if a patient does fall, and this could help you with determining the underlying reason for the patient's fall or determine the extent of injury from the patient's fall. These diagnostics could include x-rays, CT scans of the head or other areas, 12-lead EKG, orthostatic vital signs, and the labs would be a CMP, a CBC, a CKMB, and a troponin. There are multiple differential diagnoses that could be considered when a patient falls. One could be a CVA, and this could be ruled out with a head CT. Another is orthostatic hypotension. This could be ruled out by obtaining the patient's orthostatic vital signs when they're sitting, standing, or lying. Another could be a syncopal episode due to anemia, and you could rule this out with a CBC and an EKG. My final diagnosis for the patient in this case study was high risk for falls related to muscle weakness and osteoarthritis. My plan for her consisted of physical therapy and vitamin D supplementation. The challenges and barriers that we could have encountered in this treatment plan were having the patient agree to attend physical therapy and the patient failing to report further falls. Community resources available to my patient would be a skilled nursing facility where the physical therapy could work with the patient twice a day without concern of the patient having to travel, or we could do home health with home physical therapy. The patient could remain at home and have the environmental risk factors removed or home assessed by home health nurses as well. The multidisciplinary team could be the physical therapist, nursing, and the primary care physician. Some health concerns that I have for my patient is that she takes hydrochlorothiazide and lisinopril daily. However, she does not take her blood pressure before taking the medication. This puts her at a greater risk for becoming hypotensive, which puts her at a greater risk for falling. She also has osteoarthritis, which could make her injuries much worse from a fall. Some social determinants for not reporting falls is fear of being placed in a nursing home, and there were no particular socioeconomic or cultural concerns with this patient. In conclusion, some interesting things that I learned during the research for this presentation is that 50% of patients in nursing homes fall. The reason I found this interesting is because we put patients in nursing homes to prevent falls or because they've fallen in the past and we want to prevent an injury. However, the number of falls in nursing homes are still very high. Also, 40% of physicians fail to ask about falls at home. And the best way to predict a fall is through interviewing the patient and assessing the patient, which again just stresses why nurses should have appropriate interview and assessment skills in order to determine this, because most falls happen more than once. They are a reoccurring incident.